apart from the prevalence of diabetes that has increased over the years, another problems that we face include the glycemic control of our diabetic patients. Now, this slide shows you the results from DietCare studies. DietCare was a hospital-based cross-sectional studies. We have two sets of data. One in 2008 has been represented in the lighter blue bar, whereas the darker blue bar was results in the 2013. So if you look at the results, whether in 2008 or 2013, you can see that less than 15% of our diabetic patients were able to reach a target A1C of less than 6.5%. Whereas if you look at individuals who are able to reach an A1C of less than 7%, it's only less than a quarter of them, which means more than 3/4 of our diabetic patients are still out of target. And if you look at their mean A1C, again, you can see their mean A1C is about 8.5 to 8.6%. Therefore, it is not surprising that in Malaysia, there is a high diabetes complication rates. So if you look at your left-hand panel, you can see results from Discover study, whereby patients with recently diagnosed diabetes, 26% of them already develop microvascular complications, and 10% of them develop macrovascular complications. If you look at your right-hand panel, the most common microvascular complications include chronic kidney disease, and the macrovascular complications include coronary artery disease as well as heart failure. We know that there are many comorbidities that can be associated with type 2 diabetes, but among the most prevalent ones include the cardio-renal metabolic comorbidities. Now, not only that there's cardio-renal metabolic comorbidities, they are prevalent, but the presence of any of these comorbidities substantially impact the treatment choices, including the selection of glucose-lowering medications, the intensity of glycemic control, as well as the choices of concomitant medications. Now, we all know that cardiovascular disease and renal disease, they are closely interlinked because each dysfunctional organ has the ability to initiate and perpetuate this disease in the other organs, okay, through many various pathways. Now, cardiovascular disease remains the primary cause of morbidity and mortality in diabetes. Patients with diabetes, they are 2 to 4-fold increased risk of cardiovascular disease compared to the general population. In Malaysia, the country spends about 1.4 billion treating people with diabetes, and out of this figure, 1 billion alone was actually treating the complications related to diabetes. Therefore, it is important for us to treat patients with diabetes much aggressively in the course of the disease in order to prevent complications from setting in. Another important aspect that is frequently forgotten but fatal is the association between heart failure and type 2 diabetes. People with type 2 diabetes has a 2 to 5-fold increased risk of heart failure compared to the general population. And of course, there is a reciprocal relationship between heart failure and diabetes. Diabetes can accelerate arteriosclerosis, causing coronary artery disease, myocardial infarct, and reduced ejection fraction. At the same time, it can cause left ventricular dysfunction, stiffening of the heart, activation of the renin-angiotensin-aldosterone system, and all this lead to cardiac fibrosis. Okay? Therefore, heart failure is a frequent condition that can be associated with type 2 diabetes. Now, another important consequence of diabetes and heart failure is the dismal prognosis that it carries. Okay? Despite advances in therapy, the mortality in heart failure remains very high because patients with the 5-year age-adjusted death rate in people with diabetes and heart failure was about 59% in patients who are men and 45% in women, which means if you have 2 patients who has diabetes and heart failure, one of them will die within the next 5 years. Okay, So the survival of patients with diabetes and heart failure plunges down dramatically once heart failure sets in. So therefore, prevention is still the main or the best strategy, which means we need to prevent our patients from developing heart failure. Now let us move on to the diabetic kidney disease. So in terms of the epidemiology of chronic kidney disease, up to 40% of patients with type 2 diabetes develop chronic kidney disease. And this chronic kidney disease occurs early in diabetes patients because, as you can see, the newly diagnosed patients with diabetes, about 26% of them already develop some form of chronic kidney disease. And it is important to note that microalbuminuria carries a poor prognosis because it has been shown that the presence of microalbuminuria conferred a 3.7-fold increased risk of hospitalization for heart failure, and this is associated with poor prognosis with a 10-fold increased risk in mortality. Now, despite the detrimental effect of diabetic kidney disease in type 2 diabetes, the awareness about this condition is very poor. You can see in a 15-month retrospective review of more than 5,000 patients with type 2 diabetes and diabetic kidney disease, you can see that about 88% of patients do not realize or do not aware that they have some form of diabetic kidney disease. In fact, if you look at the stage 4 and stage 5 diabetic kidney disease, 40 to 50% of them do not know that they have these stages of diabetic kidney disease. If you look at the lower hand panel, you can even see those in the stage 3A or 3B. Again, more than 50% of them and 1 in 3 of them do not realize that they have this degree of diabetic kidney disease. So I think it's important not only that the patients do not aware, I believe that even some of the healthcare professionals might not realize that the patient have diabetic kidney disease if they only rely on creatinine levels. Therefore, it is important to calculate the eGFR and look at the proteinuria or albuminuria that the patients have, because detection of diabetic kidney disease early in the course of the disease is important, because there are some drugs or preventive measures that can be taken to prevent progression of chronic kidney disease. Now, diabetes and CKD or end-stage renal disease has been associated with frequent hospitalization. People with diabetes are 6 times more likely to be hospitalized for chronic kidney disease and 12 times more likely to be hospitalized for end-stage renal disease. And again, diabetes is the commonest cause of new onset end-stage renal failure. And in Malaysia, the diabetes accounted for about 65% of the new onset end-stage renal disease. Now, it is important to highlight that once your patient develops end-stage renal failure, about 40% of this individual will have overt heart failure. And this is associated with very poor prognosis because their median survival will be about 3 years compared to individuals who do not have heart failure, which is still at 5 years. So again, patients with chronic kidney disease, they are 5 to 10 times more likely to die from a cardiovascular event than progressing to end-stage renal failure. It has been shown only about 10% of patients actually survive into the end-stage renal disease. In a study by Wen et al., it has been shown that the lifespan loss in an individual who has chronic kidney disease, the lifespan is shortened by 6 years. If a patient has diabetes, the lifespan is being shortened by 10 years. If the patient has a combination of chronic kidney disease and diabetes, then you can see that the lifespan is being shortened by a substantial 16 years. Therefore, more effective measures to prevent and treat chronic kidney disease in diabetes are urgently needed. So more than a decade ago, limited cardiovascular benefits have been observed with intensive glycemic control in patients with diabetes, and this stems from the ACCORD, Advanced, UKPDS, and VADT studies. If you look at the kidney disease, similarly, despite treating risk factors into goal, there's a significant residual for kidney disease progression. Of course, until recently, with the availability of the new classes of agents in treating diabetes, and of course, in particular, the SGLT2 inhibitors, the treatment paradigm has changed tremendously. Now, just briefly, because I'm sure many of you would know in terms of the mechanism of actions of SGLT2 inhibitors, we know that SGLT2 inhibitors block the SGLT2 cotransporter that are located at the S1 and S2 segments of the proximal convoluted tubule, and this leads to glycosuria and natriuresis. Of course, this translates to clinical findings of reduction in the plasma glucose, body weight, blood pressure, uric acid level, and albumin excretion. All these clinical effects, including the improvement in the preload as well as the afterload, resulted in improved renal as well as cardiovascular outcomes. Now, SGLT2 inhibitors, we know that it was originally approved as a glucose-lowering agents. Cardiovascular and renal outcomes data have demonstrated that this class goes beyond glucose lowering. I will take you through to all these clinical trials and summarize the results of these SGLT2 CVOT trials. Now, at present, there are 4 SGLT2 inhibitor cardiovascular outcome trials that have now been completed. Of course, it first started with the EMPA-REG outcome trial that used empagliflozin back in 2015. This then followed by CANVAS, which uses canagliflozin, subsequently DECLARE with dapagliflozin, and the recent one is the VERTIS-CV that uses ertugliflozin. Now, if you look at the metabolic findings of all these clinical trials, it looks like they have almost similar class effect because they are potent in reducing the A1C. The A1C reduction by all these SGLT2 inhibitors is about 0.7 to 0.8%. Of course, this is a mean A1C reduction. If your patient has a higher baseline A1C at the beginning, of course, you would see a greater A1C reduction. In terms of the body weight changes, you can see that these agents causes reduction of body weight by about 2 to 3 kilograms. And in regards to systolic blood pressure, it reduces the systolic blood pressure by about 3 to 5 millimeter mercury. Now, if you look at the cardiovascular outcome trials with regards to their baseline characteristics, we can see that in terms of the duration of follow-up of all these CVOTs, it ranged from 2.4 to 4.2 years. The age of the individuals, they're almost similar at about 63 to 64 years old, with an A1C of about 8%. All these clinical trials involve patients with long-standing diabetes ranging from 10 to 13 years. The only significant difference between all these clinical trials include the participants involved in these clinical trials, because we can see that in EMPA-REG outcome trial as well as in VERTIS-CV trial, almost 100% of their patients are those with established cardiovascular disease, whereas in CANVAS, there was only 66%, and in DECLARE, there was 41% with established cardiovascular disease. Another important difference is the history of heart failure at baseline. You can see that patients in the VERTIS-CV, the proportion of heart failure at baseline was actually double compared to the other cardiovascular outcome trials with EMPA, CANVAS, or DECLARE. Another important aspect is the kidney function, because although consistently in all these patients, most of the patients had an eGFR of above 60. You can see that individuals with eGFR of less than 60 range from about 20 to 25%, except in the DECLARE study, which only have about 7%. And this is not surprising because DECLARE, when it was first started, the dapagliflozin was licensed for only patients with an eGFR of above 60. So all these clinical trials have similar primary endpoint, which is the 3-point major adverse cardiovascular events, which include cardiovascular death, hospitalization, cardiovascular death, non-fatal MI, and non-fatal stroke. So if you look at the 3-point MACE in all these clinical trials, there was a similar significant 14% reduction in the 3-point MACE seen in the EMPA-REG outcome as well as the CANVAS program, but the 3-point MACE were neutral in DECLARE as well as VERTIS-CV trials. If you look at the cardiovascular death endpoint, there was a significant cardiovascular death endpoint in the EMPA-REG, but this was not seen in the CANVAS, DECLARE as well as VERTIS-CV. When it comes to the hospitalization for heart failure, you would see a class effect whereby in all these clinical trials, patients who were randomized to receive SGLT2 inhibitors, there was a significant 30 to 35% reduction in hospitalization for heart failure in these individuals. What about the renal outcomes in these SGLT2 inhibitor CVOTs? It is important to remind ourselves that these renal outcomes in these CVOTs are actually the secondary endpoints. Therefore, the exploratory analysis showed that the renal outcomes was significantly positive, or it shows beneficial effect in EMPA-REG, CANVAS, as well as DECLARE study. So to summarize all these CVOTs, as you can see, in terms of the 3-point MACE, it was significant in the EMPA-REG as well as CANVAS. Cardiovascular death was only seen in the EMPA-REG. The hospitalization for heart failure was beneficial across all the CVOTs, and the kidney outcome trials, or the kidney outcomes of these trials was seen in the earlier 3 studies. Now, because of the nature of the renal outcome trials, or the renal outcome in the CVOTs was a secondary endpoint, therefore CREDENCE study was conducted to assess the renal outcomes as its primary endpoint. Now, CREDENCE was conducted in patients with type 2 diabetes and albuminuric chronic kidney disease with an eGFR of between 30 to less than 90, and their albuminuria was between 300 to 5,000 milligram per millimole. And this study was terminated early at 2.6 years because of the beneficial effect seen. As you can see from this slide, patients who received SGLT2 inhibitor canagliflozin had a 30% reduction in the composite endpoint of end-stage renal disease, doubling of serum creatinine, renal as well as cardiovascular death. Therefore, since 2016, the guidelines have changed dramatically, whereby most of these guidelines have recommended the use of SGLT2 inhibitors and GLP-1 receptor agonists for their cardiorenal metabolic benefits. You can see 2015, before the 2015, the focus of the guidelines were mainly on glycemic control, but since 2016, you can see it has been expanded to include the cardiovascular and mortality benefits. Subsequently, we see more evidence on the heart failure as well as the nephroprotection of these agents. In 2020, again, it has renewed its focus, whereby patients with established cardiovascular disease, heart failure, or chronic kidney disease that predominates, then these agents should be prioritized independent of patients' A1C level. Now, all these clinical trials have drastically or dramatically transformed the clinical guidelines, not only in the diabetes or endocrine fraternity, but also in the cardiovascular or cardiology as well as nephrology fraternity. So if you look at the American Diabetes Association treatment algorithm in patients with type 2 diabetes and cardiovascular disease, of course, the first line, they advocate metformin and lifestyle modification. Subsequently, independent of the A1C level or individualized A1C target, if the patient has established cardiovascular disease or at high risk of cardiovascular disease, then preferably a GLP-1 receptor agonist or SGLT2 inhibitor with proven cardiovascular disease benefit should be. An Association of Clinical Endocrinology seems to agree with the ADA guideline. Similarly, independent of the glycemic control, if the patient has established cardiovascular disease or at high risk of this disease, or they have chronic kidney disease or heart failure, then SGLT2 inhibitor or GLP-1 receptor agonist is being recommended either as a monotherapy, dual therapy, or triple therapy. What about in Malaysia? In Malaysia, in terms of the type 2 diabetes management guideline, it is currently being updated as we speak. At the moment, the latest that we have, another CPG, is on the clinical practice guidelines on the prevention of cardiovascular disease 2017. You can see that even during 2017, in this guideline, patients with diabetes and cardiovascular disease, as well as those with high risk, we can see that SGLT2 inhibitors are being placed at a much higher in this algorithm. What about the cardiology guidelines? So the 2019 European Society Cardiology with EASD recommended if the patient has or is already on metformin and they have established cardiovascular disease or at high risk, then it is recommended to add an SGLT2 inhibitor or GLP-1 receptor agonist. If they are drug naive and they have established cardiovascular disease or at high risk, then SGLT2 inhibitor or GLP-1 receptor agonist is being recommended even as a first-line therapy. If let's say the A1C is still out of target, then other appropriate agents can be added subsequently. What about the nephrology? So the KDIGO 2020 guideline recommends treating patients with type 2 diabetes, chronic kidney disease, and those with eGFR above 30 with SGLT2 inhibitor and metformin in view of its nephroprotection. So what are the other studies that are currently ongoing? So we know that the DAPA CKD has recently been announced, which again confirm or affirm the role of SGLT2 inhibitors in preventing the progression of chronic kidney disease. We will await for EMPA kidney that will end its trial in 2020. And you can see there are other classes of agents that are being tested in patients with type 2 diabetes and chronic kidney disease, and we will await for all these results in the coming years. So in conclusion, diabetes is a growing concern in Malaysia. Recent data suggests that prevalence among younger age group is increasing. The heart and renal complications are frequent, early, and under-recognized in type 2 diabetes, resulting in significant morbidity and mortality. A patient-centered approach should be used to guide the choice of pharmacologic agents, and among patients with type 2 diabetes who have established cardiovascular disease or indicators of high risk, established CKD or heart failure, then SGLT2 inhibitor or GLP-1 receptor agonist with cardiovascular disease benefit is recommended as part of the glucose lowering regimen independent of the A1C level. Thank you.